So this is the third session of our series. They are being held Wednesdays at 12 p.m. Eastern Time. The same Zoom link is used for all the sessions. The recordings are available on our website for the first two sessions. And coming up next Wednesday, we have a panelist of people working for research development and other opportunities. And then the last one of the session on July 26th is Stepping Stones. So these are people who have or are currently in roles that gain a little experience before moving on to further education. Thank you all for providing your questions. When registering, they've been really helpful. We've added some of them to the panel of questions today. In addition, there will be a Q&A box if any of you have questions for the panelists today, and you have the ability to upvote, and we will talk about them live. Okay, before we get started, I have a quick poll. There are just two questions just to get a little bit of an idea of everyone who's on the call. So the first question is just asking everyone, as of September 2023, will you be a student? And then the second question is asking a little bit of what is your familiarity with the physician career path? All right, excellent. So it looks like the majority of our folks are not currently a student, so maybe you're trying to decide where you want to do, where you want to go. So this will be great to get a little bit of information of what is the path and what are the steps you need to take to head down the physician career path. In addition, we have a few students who are undergraduate, which is also great. And then we have a range of familiarity with the career path, starting with people who are not familiar at all to somewhat familiar or very familiar. So I'll just take a minute to share the results. Everyone can take a look. And before we begin, I am going to just give a few background slides, a little bit background slide to give a sense of the physician career path, and in particular, the clinical genetics. Some of our panelists might be boarded in different specialties, which I'll tell you more about. So first, let's kind of level set, and we say genetics is relevant in many medical specialties, from endocrinology to orthopedics. It is unlikely that you will find a field in which genetics will not play a role. Many practices are thinking about genetics and caring for patients with genetic conditions. So what is a clinical geneticist? Clinical geneticists are physicians who care for patients in a clinical setting. They can also carry out different research that will help improve patient care. They hold an American Board of Medical Genetics and Genomics certification in the specialty of clinical genetics and genomics. They have broad training in the evaluation, diagnosis, management, and treatment of inherited conditions. They see patients from a wide range of ages, from birth to adulthood, and they often intersect with many other medical disciplines because of the wide-ranging effects of genetic conditions. So how do you become one? I'm going to talk a little bit about the path that's focused here in the United States and maybe a little bit different in other countries. So in the United States, it usually starts with a bachelor's degree, which can really be in anything as long as you do the course requirements to apply to medical school. From there, you go on to medical school, and in your fourth year, you apply to a residency through the MATCH program. Following medical school, there are a few different paths in residency that can lead you to be a clinical geneticist. You have to complete at least one residency year in a primary specialty, followed by 2 years of medical genetics and genomics residency. There are a couple of different options. Some programs will allow you to do a combined program, and then there are other programs where it allows you to apply to that genetics residency after you complete that primary year residency. So As we said, there are a few paths, and this is just a flow diagram that kind of outlines how it might work. So someone might start in a primary specialty, say pediatrics or OBGYN, family medicine, sorry. And then after they complete that 1 year, or if they decide to complete that full residency program, then they'll apply to the medical genetics residency program, which is an additional 2 years. And then they are eligible for the ABMGG boards. And others might just apply to that combined program, which would start with the initial year in one of these specialties and go straight onto that medical genetics residency. So the time of training can vary depending on what path you take and how many years of each of these residencies or training you complete. So there's no kind of set answer on the duration or the time until you complete the training. There is a range of career possibilities. The majority of clinical geneticists work at a public non-commercial institution like an academic medical center or university. Others may opt to work at a private genetic testing company or work in private healthcare services. If you want to learn more, there are a couple of resources. The American College of Medical Geneticists does allow student members to join for free, and you can learn more about the resources available there. In addition, there's information on their website for those who might be interested in learning more about the residency program. If you give me 1 second, let me just put the link in the chat so that you guys all will have that information going forward as well. Okay, so we have a great slew of positions for y'all today. We are going to go around. They are going to introduce themselves, to kind of tell us all a little bit about themselves, where they work, and how they got there, a little bit their training in the background. We have a few questions that you all submitted before where you're registering that we'll ask them. In addition, don't be afraid to post any questions in that chat. Sorry, not the chat. Let me rephrase it. Post any questions in the Q&A box so that we will ask the panelists during the session. So I'm going to stop sharing my screen, open it to the panelists, and we're just kind of go around in a circle from what it looks like for me. So Dr. Gold, if you want to start, tell us a little bit about who you are, where you work, what your day-to-day looks like, and a little bit of your training and background.
Sure. It's really nice to join you all today. So I'm Nina Gold. I am a medical geneticist and metabolism doctor at Mass General Hospital in Boston. And I basically came to genetics because I decided to take a year between college and medical school, and I sort of happened to be a research assistant for a medical geneticist. And I really loved the way that genetics combined this really interesting science with also this very human element, and in particular, that job for me involved speaking with mothers of new babies with congenital anomalies. So I really enjoyed that, kind of opportunity to be involved with families in that way, and just sort of stuck with genetics all through medical school. So I went to Harvard Medical School, and then I did the combined pediatrics and medical genetics program at Boston Children's Hospital, and then did my metabolism fellowship at the Children's Hospital of Philadelphia, and came back to Boston to become an attending. And I'm now in my 4th year as an attending, and I do kind of a combination of clinical work and research right now.
Thank you. And then underneath you, I have Sulin.
Hi, everybody. This is Sulin. I am actually a new graduate from a combined genetics and a medicine program at a Case Western. Beforehand, actually, I went to school at UCLA and in Michigan for my MD PhD route. I was trending systems biology and bioinformatics, and throughout my residency at a Case Western, that was really exciting and a very eye-opening experience, because at a Case Western, we have 3 hospitals all combined on site and also standalone cancer center. So as a medicine trainee, I get to see all those patients established with my attending. A lot of them actually already moved into adulthood. So we get to learn about the care coordination in terms of different subspecialties for medicine, especially Case Western and Cleveland Clinic were very focus on the cardiology of abnormalities. And also on our program, we also have a biochemistry and a metabolism, even laboratory attendings on site. So we also cover those calls to learn about the management in terms of the newborn, abnormal newborn screening and all different subsequent treatment. And also at Case Western, we got a chance to actually to participate and learn about the clinical trials that through phase 1, 2, 3, like myself, I was participating in different gene therapies and targeted therapy and biochemistry pharmaceutical studies to support the genetics and metabolism patients. I'm currently a fellow at U Chicago for hematology oncology, and I'm also on the research track for pharmacogenomics as well. Thank you so much.
Excellent, thank you. And then I have Dr. Powell.
Hi, I'm Bradford Powell. I am a medical geneticist and pediatrician at the University of North Carolina in Chapel Hill. I think I was of that path that did a complete pediatrics residency and then a genetics fellowship afterwards. The thing that was different about my path is that I didn't, which is not mentioned in that, is I was part of a combined MD PhD program for my undergraduate medical education, or that part after undergraduate. So that was an extended period of time where those programs are set up so that typically you do the first 1.5 or 2 years of medical school, then do research training, and then come back into the last part of medical school, the remainder of the clinical training. Currently, I am working in my area of specialty within genetics is in cancer predisposition. So I do work and work with families ranging from children to adults that have suspected predisposition to cancer related to an inherited condition. And on the research side, and I know there's a separate research talk, but I think I've already noticed within a couple of people here that this is a field where we very closely touch upon research. I do a fair bit of work within informatics as well, and that's a large portion of my daily effort. In addition to teaching and all the other things that you do in academic medical center. So one of the lines I used in my applications for the genetics training was that genetics is not the field that I'm most interested in. It is the many fields that I'm most interested in. And one of the things I liked about it is the ability to combine the clinical interests, the research interests, the involvement in teaching within an academic medical center. And the fact that if you're indecisive like me about which field of medicine you like, you get to interact as a clinical geneticist, like I said earlier, we get to interact with neurologists and nephrologists and hematologists and maintain at least some knowledge in each of those areas.
Thank you. And then we have Dr. Goldwasser.
Hi, everybody. I'm Tamar Goldwasser. So my path is that I went to medical school to take care of women. So I have a lot of sisters, and women were important in my life, and I wanted to go into women's health. So wasn't sure where I was headed. Then I fell in love with OBGYN during my medical school training, and I'm an OBGYN. I did the 4 years of that residency. But I always was inspired by some other geneticists who, luckily, where I trained at Montefiore, I had a lot of interaction with OBGYN geneticists. And whenever they gave us lectures and whenever they were part of the discussion, everything lit up in my brain. And I was so excited. And I thought there's so much more I can give to my patients. And so from there, right after I did the medical genetics residency after OBGYN. And now I do all clinical work, mostly in the reproductive genetics space. So I'll talk to a lot of pregnant patients. I read prenatal ultrasounds. I do amniocentesis and CVS procedures, and I do consultations for patients with complex results, either in a pregnancy or when planning a future pregnancy after having something in a prior pregnancy. I'll consult with IVF doctors on results of embryo testing. And I also do once a week, I do cancer genetics at Englewood Health. We have a cancer center, and primarily adults. But I get to see men and women and talk to them about hereditary risk for any type of cancer. And, you know, it sometimes seems like two separate things, but I feel like when it comes to genetics and you diagnose a patient either with a hereditary cancer predisposition or any other genetic diagnosis, you really are diagnosing the whole family, and it leads right into their reproductive counseling and reproductive options that are available. And so I feel like it's a really good continuum, because I say to my patients, I'm thinking about you in the context of your whole entire family. So it's really enjoyable.
Well, thank you all. I love the diversity here and then the different areas they all work in and how you got there. Kind of, if you were going to go back and talk to yourself, 10, 15 years ago, what would be some advice that you would give someone thinking about pursuing this career path? Is there anything you would suggest for them to enhance their application, help them prepare for this path going forward?
I'll just jump in and say, I used to work at Montefiore and I did a lot of teaching of medical students. And I would say, if you're on this ClinGen panel, you already know how cool and interesting genetics is. I think it's a challenge for our field, like, us doctors, to improve awareness, because I don't know if everyone knows that we're out there and how amazing our jobs are. I always say, other doctors don't know they need me until I've taken care of one of their patients, and then they want me to see a lot of their patients. So I would say, if you're interested, one good thing is that I don't think that it's a crowded field. So I think you have a good chance of being successful if you reach out and make connections. Those of us in the field are very happy to welcome students and to bring them along and mentor them and involve them in research and clinical care. And so I think it's a matter of reaching out and making the connections. I think it's a really nice family of people who work in the genetics clinical space, and we're very receptive. That's just my big piece of advice.
Yeah. And also I want to join in this part. As a newly graduate, what I've learned so far is also like genetics is not just about what we read on the book. It's actually a truly patient you see every single day. And those are some very complicated patients. They have some very rare condition. We start to support them from beginning of the life. And we eventually will get involved with the whole family, because there are some like a hereditary patterns there. So it's actually very long-term interaction and very nice bond with the family. And also you start to get more roles in the medical education, just to raise awareness. And also because it's a medication and also the overall support has grown so well for different patients. So we have more and more patients actually grow into their adulthood. And even with a different medication, there's a lot of symptom support. So it's no longer just something we see the pictures in the textbook. It's daily life. And also in terms of the medical practice, for different subspecialty, we start to use more and more molecular test-based diagnosis that actually help us to further differentiate some subtypes, or even to pick those like a unique or more useful medical treatment. So I would definitely say, this is a coming up field that's drawing a lot of attention, and we support not just about genetics patient. It's actually we support all different kind of subspecialties at different age groups. So it's actually very well the communication in terms of the academic research and also QI project to support the whole community.
Yeah. And then I think I'll just add, like, sometimes it's hard to find someone to shadow. I know my institution puts up a lot of barriers for undergraduates, and like, I wish it wasn't that way. But one way to kind of get more information about that personal side, if you can't immediately get into the clinic, there are a lot of really wonderful books that families have written, kind of coping with their own genetic diagnosis story. So there's one that I really like called The Family Gene, or there's another one called Mercies in Disguise. And those are really kind of wonderful ways to understand from the inside, not just how we think as doctors, but what is it really like for these families living with these conditions and how they reach and affect all these different members of the family.
And there's not a whole lot to add to those other than thinking about the different people who are at different stages of education here. There are some who are undergraduates who are like, is medicine right for me? Is being a physician versus being a genetic counselor right for me? And I agree that getting to know people the best that you can, enrolling, joining ACMG as a student member, which is great that you can do that for free. I found that out today. Do that sort of thing. If you've started medical school, the ACMG Foundation has a program for folks after their first year of medical school to spend some time that summer with a geneticist or a genetics group. Some of that might be research, some of that could be clinic. I think really important is there are so many different things you can do as a genetics clinician that if you know one person who does it, you know one person who does it. And getting that variety of exposures can be helpful as well.
Thank you. That's a lot of wealth of information, and I appreciate it. We did receive a question. How are the responsibilities and duties towards a patient delegated between you and the rest of the healthcare team, like nurses or genetic counselors? Do you always work with the team? Is it more independent? Tell us a little bit about how your practices are set up.
So I work with genetic counselors both in my clinic and in research as well. And, we work as a team. I think one thing that differentiates us as physicians is, for me, I'm a metabolism doctor as well, which means that I kind of focus in particular on a group of genetic conditions that, we say has to do with the way the body makes energy. But what that practically means is that these are often children and adults who have a lot of medical needs and may end up hospitalized if they get sick. And so for me, one of the main differences is that I'm really the person who is evaluating the patient when they might be ill, helping to decide what their medications or their diet is like when they're well, and then also when I take call, which our genetic counseling team at my hospital doesn't do, and that varies by hospital. I'm, kind of the consultant on call to help to decide how to manage that patient's medication. So, that's just one niche within genetics. Not everyone does that, but for me, that's one way that being a physician differentiates me from some of the other people on my team.
So I think you're going to get a lot of different answers here as well because of the different ways that people practice. I work very closely with genetic counselors. They are, I've said before, one of the best parts about being a medical geneticist is getting to work with great genetic counselors who have there's this balance of the time that they will often have to follow up with families afterwards to do additional psychosocial counseling beyond what I can do as part of my visit. So we actually have different models for different clinics. For a lot of the adult cancer genetics clinics, there's actually a genetic counselor who will be the primary person that sees them, and I am available if needed. Similar to how a PA might see patients primarily and have a physician available for when there are more difficult or more complicated cases. For the pediatric cancer predisposition, though, we do that as a team clinic. So I am there present, and sometimes we'll do the split mode where there's a genetic counselor goes in first and then I go in afterwards. And sometimes we'll do that together because of the additional psychosocial issues. We have found it's helpful to have two clinicians in the room with slightly different areas of expertise that are complementary as part of that. So there's a mixture of that. You also have heard before that genetics is a small specialty. There's not many of us, and there's often a lot of demand. And so we've had to be creative in our healthcare system for how we manage that, meaning that a lot of the times I'm not the one involved in the long-term management of the patient, but I work with, I communicate with the primary care providers or with other specialists to help guide, to help provide input on how to guide that. So there's a lot of interaction with other physicians within the healthcare system as well.
Okay, so I would say, so for me, when I worked at an academic center, I worked with a lot of full-time genetic counselors, and I would say they would see the patient first, and then they would basically do the entire assessment, whether it was reproductive, prenatal, preconception, or cancer, make an assessment, make a recommendation, and then I will come sort of like just a recap with the patient, with the genetic counselor together. Sometimes you end up eliciting a little bit of extra information or new information, and I think usually it's not too different, and I wouldn't necessarily have changed the plan from that an experienced genetic counselor had already developed and made. And then I felt like my role was just to kind of sew it all together into the health system, whatever the results were, be sure that the doctors who need to know understand the recommendations, and I would communicate with the other doctors, and just kind of make sure that everything that came out of that session was integrated into their healthcare plan. And I learned a lot from genetic counselors who were able to focus on whatever specialty it was. So if it's reproductive or cancer genetics, sometimes they had much more up-to-date or in-depth information or experience with certain labs or certain genes or certain specific recurrent variants. And so that was very, very helpful. And because in that setting, I was also delivering babies and doing prenatal care visits and teaching medical students. And so sometimes didn't have the time to do that in depth or have that much deep knowledge of that very specific specialty. Now I'm in a private practice for my prenatal side, and I work with genetic counselors, but they're mostly genetic counselors who are working from a lab. So they actually don't work for me specifically, but we do share, and I ask them to reach out to me whenever there's a complicated case related to one of our private practice patients, but it is different. And at this point, they serve as like maybe extenders for our practice, because we you know, for whatever reason can't afford or can't hire our own full-time genetic counselors. And so I would say it's something interesting to think about. And when you think about like where genetic counselors work, a lot work in academic centers. And again, because the big academic centers completely understand and know that they need genetic counselors in these fields to responsibly roll out genetic testing and utilize it in the proper way. But a lot of places find that it's expensive, and there's a whole issue in terms of how do genetic counselors bill and who's responsible. And so, you know, in my private practice, we don't have the privilege of having full-time genetic counselors. And so I'm doing most of that stuff on my own. When I see a case, it's usually a complicated case, and I'll start from scratch, do the whole history myself, and do all the pre-test and post-test counseling myself and documentation. So it's changed.
Yeah, I also want to share about a Case Western, because we are actually academic area, and also we work very closely with the Cleveland Clinic. And one thing I want to share with you all is that actually we do have some summer internship program. We have a lot of genetic counseling or pre-genetic counseling students apply for those summer internship to come to join us. And for undergraduate student, we also have some GCA, so those genetic counseling assistant spot opening up routinely throughout the whole academic year. So they get to see the overall practice, and they also help us place order and process some lab-related information as well. And because at our academic center, in addition to the genetic counselor, in addition to a physician, we also have the LGG, that's a laboratory fellowship. So we actually get to work very close with them actually in terms of some sample processing and some raw data information in terms of the research, but that also facilitates the overall process about information obtaining for patients that actually needed urgently. And all our providers work very, very closely with the genetic counselor. We actually have 4 different major groups of genetic counselor there. We have a cancer clinic, we have a prenatal REI, we also have interdisciplinary. So the interdisciplinary team is actually disease-based. We have a Prader-Willi, we have an AYA for hematology. We also have a craniofacial and a vascular. So those are actually the joint meetings actually between different levels of providers to support the patients. So patient only have to come once, and all the providers were rotating through the room to catch up with them or to plan any procedures they need. And in terms of our attendings on site, it's very interesting because we have attendings that are multiple boarded. So we have attending who is the pediatrics, peds neurology, and also genetics. We also have attendings actually medicine, urology, and medical genetics, and a biochem lab. And so there's actually a very good combination in terms of the academic setting and to provide patients with a very diverse, yet it's actually integrated cares for medical genetics centered treatment plan.
Thank you, everyone. I know we briefly mentioned it, and some of you mentioned that you guys are also doing a little bit of research, and I'm happy for you all to share a little bit about how you incorporate research into your work, how you guys got involved with research, and how it interplays with your clinic. It's a totally separate.
We don't have an order. I'll go first on this one. So I think it's kind of segue. This is a great segue from the previous question, because part of the reason that I feel like research is possible with what I do is because that some of those day-to-day aspects of following up on patients with test results that the genetic counselors can help with. I think it would be really hard to do the amount of time that I have devoted to research without that. The research that I do is it is at the very translational edge of it. So I'm involved in ClinGen. So actually there's a fair bit of my time that's involved in the ClinGen actionability working group. Plug in for that. It's great work that group does. But there's also aspects of how do we incorporate genetic information into the clinic, which is a very broad topic. Some of that has to do with evaluation of when is exome appropriate. Some of it is looking into where might population genetic screening be appropriate. So a lot of it is very separate from my clinic. I'm not the kind of doctor who's recruiting patients directly from my clinic to be involved in these studies, in part because just the way that cancer genetics is, there's not the kinds of diagnostic dilemmas, or there's not the kind of number, hundreds of genes that could be associated with a condition where we do exome sequencing with that condition in particular. So the balance is that I have to be part of a group that's willing to say, I have these numbers of days a month that I'm in clinic, and these numbers of days a month where I'm able to do research, and making sure that there's clinical coverage for the time that I'm not able to be in clinic or not able to be on consults.
So I'll add to that. I came into my position after training thinking that I wanted to be primarily a clinician. And initially I took a job that was 75% clinical. I started working right before the pandemic and right before I had my first child. And I realized that I had a lot of questions that I wanted to answer, but that also adding that research component added more flexibility to my career. So when I got pregnant with my second child, I decided to apply for a K08 award, which I started about 6 months ago. And it has just been the most amazing experience, because instead of doing 75% clinical time, I now do 75% research time. So I still get to be in the clinic and see patients, which is something I never want to lose. I love that. That brings meaning to my work. And I think each of the pieces is complementary, and my patients make me a better researcher, and my research makes me a better doctor in the clinic. And so my research has to do primarily with kind of understanding the implementation of genomic newborn screening, and then also in particular, better understanding the expressivity and penetrance of rare genetic variants. So understanding who actually goes on to develop disease. I think that's sort of adjacent actually to what Dr. Powell does as well. I am really excited because I actually get to take master's courses this year. Like I'm going back to school, and that is such a cool opportunity that I can do as a physician. So I think, sometimes when you go into medicine or whatever career path you choose, you think it's one thing, you think it's whatever your mentors did or whatever the classic pathway is, but along the way, I've sort of changed course in a few different ways, and you can pick the things that are most meaningful and exciting to you, and go with that, and make it work for you in that time of your life.
So some of us are just recidivist students. We just can't stop going back to more classes.
Definitely. I mean, I'll share, I don't do clinical research right now, but in terms of what Dr. Gold said about how exciting it is to learn, I would say this field is the most exciting field. It's always something new. So you'll never see me say, oh yeah, this is just routine. Like there's literally never a case that is routine, and there's always new information. It keeps you humble and curious and excited. And so every case, even if I think I know it, I'll always check again. What is the latest information on NCCN? What does ClinGen say? What does ClinVar say? What are we doing with this now? And it really keeps me on my toes, and it keeps me learning, keeps me open-minded. You realize that whatever the knowledge is today is not static. It's constantly expanding. We're learning broader range of phenotypes for mutations that we've always known about to cause one very specific disease, now that more people are getting tested. So in genetics, you're a lifelong learner. That's it. You're signed up for that.
There is always new things to learn. And on that thread, we did receive a number of questions for some of what you guys predict kind of what will be coming up in the future. So keeping in mind, these are the few different questions people had in terms of like precision medicine and and then the expansiveness of genetic technologies and how more people are getting tested, and population genomics. Where do we see that impacting our field or your field and what you work? So you could touch on that, or where you kind of see the field going, the future of your practices and what may be coming down the line.
I mean, I think we're probably going to be integrating genomics more into kind of screening in different capacities. I think, right, like with cancer genetics already, there are guidelines from the NCCN of when we should be doing that. They're not always implemented, at least at our hospital, when they should be. So I think there's so many steps, right? Like making the recommendations based on evidence, and then also implementing them, and then changing behaviors and getting physicians to understand them. There's so many steps for that. But also, thinking more about, when, right now, I also work with our prenatal group, and we use fetal exomes for fetuses with anomalies. Are we going to start, as there's more fetal therapies available, screening fetuses who might benefit from therapy? Or is newborn screening going to be expanded? Should adults, have a routine carrier screening visit instead of just hoping that, they kind of think of getting carrier screening on their own and connect with an OB-GYN or primary care doctor who does it? So I think taking genomics and the promise of it and actually implementing it in a standardized way into care is hopefully part of where we're headed.
Yeah, I agree with all that. Again, this is very much in line with some of the research that I do and how we implement this. And one of the challenges for genetics is that physicians who are not geneticists are going to need to know a lot more about this. And that genetics is a field we're probably going to have to let go of some things. Like it's not our field anymore. At some point, there's not enough of us to handle the amount of screening that we've done, which means that we have to develop some new techniques for educating patients about things, so that, and educating other providers to be able to let people know why we would do this, why we would do what, you know, I think the carrier screening in all people of reproductive age is a great example of something that's intentional, it's intensely actionable, and but also potentially very complex. How do we get people to the point of understanding what that is, and at the same time making sure that OB/GYNs in their general practice can be comfortable with that, or that people who are breast cancer surgeons, that's their primary area of focus, that they might be comfortable ordering at least some genetic testing when it's appropriate. And which gets to how much psychosocial research and you know, the National Human Genomes Research Institute for over 20 years now has had a significant portion of their funding towards ethical, legal, and social implications, including most grants that come out of that have some component that looks into that. How do we know when it's appropriate to test for things? How do we appropriately educate patients to make decisions about what they need to, when we don't have enough genetic counselors to do that either? You know, we don't have enough genetic counseling programs to train enough genetic counselors to do that, unfortunately. But at the same time, the field is going to that. There is so much more information that we can obtain. It always comes in fits and starts, and part of the research is when are we jumping ahead of our ability to really predict what we think we can predict, which is another aspect of ClinGen that I'm not as involved in, but there's important aspects of there. I'm going to keep plugging ClinGen because we're on a ClinGen call.
Yeah, I want to off of what both of you have just said, you know, I think a huge challenge is educating our colleagues, like other medical professionals and the public, on all the different genetic concepts. Because when I meet someone in the beginning of her pregnancy and I say, here's what's available, what do you want? And I quickly explain all the genetic concepts, I don't think it's fair, and I don't think we can expect the patient to be able to make an informed decision about what test she wants, because you just explained to her what's a chromosome, what's a gene, what's a copy number variant, what is genetic information that's passed on from parents to children. Like, you know, there's just so much information and so much knowledge that we need to just increase knowledge in the public space. So I've been thinking, you know, like from when I was a child, there were a lot of commercials, and I just feel like there need to be public service announcements that are constantly put forward so that people understand what we're talking about. And, you know, carrier screening is a great example. Everyone needs to have carrier screening for not just one or two conditions. And I think it's very disparate at this point in the country. Maybe some of the bigger cities, people get lots of carrier screening, and some smaller towns, people get no carrier screening. And so you'll end up having different communities bearing a greater burden of unexpected genetic diseases in their children. And so I think the carrier screening one is a great one. And in carrier screening, so what has happened is genetic testing has become really fast, really efficient, and the price point keeps coming down. And so we're able to offer genomic testing to all patients who need it, because the medical community support that in terms of newborn screening and carrier screening. The problem is that we need a workforce to handle that information. So help people understand what tests they're having, because what does happen sometimes is people get a diagnosis and then they are very upset because they didn't realize they were going to potentially learn something about their own life or their own potential medical issues. And so, although it's useful, I think like the challenge is, we know it's available. We know that we can test everybody's exome. Like we know that can come and we can use it, but it is definitely dangerous. And you don't want to have a backlog of people with information that wasn't properly explained to them. Patients can use the information to make decisions that are irreversible, like doing a mastectomy to prevent cancer if they only had a variant of uncertain significance found on a test, or terminating a pregnancy because a blood test predicted that there was a chromosome abnormality, and the patient not understanding that it wasn't a diagnosis and it needed to be followed up with a diagnostic test. So I think the challenge of educating the public and the medical community is what's going on right now in my mind.
And I see that as a success for our field. If we get to the point where the technologies that have been developed in research have gotten so well established that other providers are able to use them, then we'll just move on to the next hard questions.
Yeah, absolutely.
Dr. Wu, I'm going to pick on you for a minute. I know you touched on a little bit of participation in pharmacogenetics, and I feel like that is up and coming. It's also another buzzword as we're talking about buzzwords and what people are testing. And if you can comment a little bit about that, how you
Yes.
incorporate that.
Sure. Yeah. So at Chicago, we actually do have ongoing clinical trials. So there's actually multiple ends. The first thing is actually we need to test about the content of the test. And the second part is about how to implant those content into the clinical charting system to alert our provider if the patient would have a specific side effect toward the medication due to the pathogenic variant. And then we have to learn from the provider and the patient who received those information, what's the best way to provide care. So that's the general layout of this kind of clinical trial. Because if we come back to the concept itself, the pharmacogenomics, there are multiple things like, Dr. Powell was talking about, and the technology is evolving. We are trying to move beyond monogenic medicine. We're trying to beyond one gene, one disease. We're trying to see what are the modifiers participating overall disease progression or even subtype. And we're also trying to see how many different genetic variants come together to give us that specific disorder condition, because that would help us to understand the progress and also to identify possible target for treatment. On top of that, it's also involved a little bit more familial and also environment factors. So like a while ago, I remember Dr. Ran gave a talk, is actually talking about how she started to sign up those polygenic score reports, in addition to the common one we've been having. So in terms of pharmacogenomics, the first thing is actually how we can use this recent technology combined with the artificial intelligence and all those like research and clinical information into the test model to identify the variant. Then the next step is actually for the pharmacogenomics to use existing clinical data to validate those pathogenic models. Then we can move on to some specific clinical trials to collect information to further validate. Then it will become clinically important and validated data that we can move on to help care for the patient. So in pharmacogenomics, it's actually the overall process about evolving the technology, improve the reliability of the result, then help to implant the result into our daily care based on genetics at a different level for both germline and somatic.
Which also touches on, there's a couple of informatics oriented people in this group, and there's a lot of health informatics research that goes into how do we make this information available when it needs to be available. When you talk about pharmacogenomics, how do we make sure that a physician is notified when they need to, but not every time they open up the chart and get bothered to the point where they start to ignore that. So there's, again, so much stuff you can do. So many great research questions, clinical questions.
I wanted to say something about AI, if I can. So I'm hoping AI is going to help me write my notes because I don't have a scribe, but I would love to have one. And I've actually tested it out and it did not satisfy what I wanted. I had a very complex conversation with a prenatal patient about the fact that she was found to be a carrier for Fabry, but that she actually might have Fabry and that we don't know how severe it might manifest in her child. And it was a male fetus. She was far along in the pregnancy. And so it was a very complicated, nuanced discussion. We talked about late abortion. We talked about adoption. We talked about recurrence risk. We talked about IVF. And then the transcript came out just like bare bones, and it really did not get into all the complexities of our conversation. But I do hope it helps me with notes, because documenting is very difficult, but very important. And I think that our role in terms of, if other people can do the testing, our role is going to still be that complex counseling. I don't think AI is anywhere near replacing what we can do in terms of guiding patients, in terms of how they can think about this, how the results impact their lives, or potentially impact, or that there's a lot of uncertainty that remains. And I think that piece, I don't think AI is anywhere near it, but helping me document would be great. And also just like looking up, let's say there's a rare finding or a rare deletion or some sort of copy number variant that came up that I'm not familiar with, to just give me the new information quick enough to search every site that I would have liked to look for. Maybe that could be something that would be helpful.
Yeah, so I'm very big on the informatics part, and there are a few things ongoing, like NEJM actually started a new AI series with a focus on integrating AI into different healthcare providers. And about 2 months ago, there's also a shared seminar between Invitae and the City of Hope, because what they are doing is actually they are using AI to collect some preclinical information to help facilitate the intake for genetic counseling for the cancer clinic. That actually shows with those like easy access interface that helps patient to enter information. It has a very high participant rate, and their response is actually pretty interactive. So they get the information within just a few minutes, while it actually may take about 20 to 30 minutes for the intake in person or on phone. And because I also coming from the machine learning algorithm, so the AI I'm looking forward to is actually like Dr. Powell was saying, that how to identify some crucial component in the structure validation, in the delivery of the data to the people who need it at the right timing. So that's how I see the informatics coming a slightly different component, help to bridging and coordinate the care for us.
Yeah, so common to other folks, I don't see AI as monolithic. There's so many different ways that it could be used well and not used well, and where we need to combine the artificial intelligence with what I like to call artisanal intelligence, like it was made back in the old days. Certainly the recognition of information, whether that is recognition of information from at the time of intake, or I think there's some interesting thoughts that people have had about how can we better recognize people that should be referred to genetics clinics at all, to try to head off a little bit. And the medical record is really hard to extract structured data from. We like to joke a lot in the field that it's a billing system that had a patient care record added on top of it. And as a result, in part because, and I am also in the clinicians that write our really, really long notes, maybe longer than they should be sometimes, because, but our discussions that we have are complex. And hidden in that complex note is that we're trying to satisfy a number of things, trying to communicate what we did to the patient, trying to communicate to the physicians. And sometimes it might be useful to have some of that information come out in a structured way so that we could use that downstream. And that's something where I think that AI, especially the recent large language models, will be useful. I think the question also asked about it with regards to ClinGen, and I can't speak for all of ClinGen other than to say that a lot of what we do is to try to get information out of the medical literature, which, like clinical notes, is it has its own kind of structure, but the structure is not always the same. And I think there's some interesting research that'll be done there. I can't hazard a guess as to whether that's for the next 5 years or the next 10 years, or and again, I don't think it's going to put ClinGen out of business. I think it'll, if anything, it will empower ClinGen to be able to do more when we can incorporate that information at a higher scale.
Yes, thank you. And coming from the Genome Connect, which is the patient registry side, we are also exploring different ways that we can get information from the medical records on the patient and their phenotype. And so another discussion to come, but another hope of where we can use AI to help us do more, do better, provide better patient care, increase our knowledge of the genes and variants by increasing that phenotype, but information available. As we've all said, that, we're expanding our information, kind of learning more and more about each of the genes and each of the specific variants. So I just wanted to take a moment to thank all of our panelists. Thank you so much for your time. Thank you for providing us with this wealth of information. Thank you so much for sharing your career paths and providing us these little amazing pieces of gold that we can carry on with us as we explore this field further. Thank you to all of our attendees. We really appreciate you guys joining. I really appreciate your questions and your engagement. It's been lovely. So I'm just going to put up the schedule once again, just so that everyone can see the upcoming sessions. As I mentioned, our sessions are on Wednesdays at 12 p.m. Eastern Time. This is the same link that you will use to attend those sessions. So if you're interested in the additional ones, feel free to log on. As I mentioned, all of our sessions are recorded and are posted to our website. So if you're unable to attend live, just they are posted at the end of each week, so you can go on and view them. At the end of the series, we will be emailing a survey to all of our all of the individuals who have registered. Please provide your feedback. This goes a long way into improving these sessions for next year, or kind of talking about or thinking about additional sessions that may be necessary. I know all of our panelists talked a lot about the need for additional education, for field education, for maybe patient education. So give us a little idea of what additional work can be done. So that is it for today. I really appreciate everyone's time. Thank you all for joining, and check out the ClinGen website. I thank you all for plugging us, but it is a wealth of information. So join in and let us know if you have any questions. Thank you.